Thank you. Good afternoon, Ms Nichols. I have just a few additional topics and questions to cover with you this afternoon. The first topic is around AGPs, aerosol generating procedures. So following on from what we were discussing this morning, in your statement, you have referred to some of the issues that your members faced with the AGP list during the pandemic, and specifically procedures that were not included on the list. And some of those you referenced this morning. Now, it's correct, isn't it, that the College of Paramedics issued a statement supporting the view taken by the Resuscitation Council UK that CPR and intubation should be added to the list of AGPs at the end of March 2020.
That's right.
And a different view was reached by the AACE, which supported the view taken by Public Health England, and that was endorsing nerve tags findings. And that statement was announced in May 2020, is that right?
That's right.
So essentially, we had statements from the college and we had statements from the AACE, and they'd reached differing views.
Yes.
And you have provided in your statement a practical example of the impact that the decision had on paramedics when responding to an emergency. It's paragraph 34 of your statement. But could you please just describe the impact of that guidance on the ground at the time?
Certainly, and if I say anything that emotionally triggers anybody who's in here or is watching, I apologise. Every minute counts when someone is in cardiac arrest. That's why it's a Category 1 call. That's why the speed of response is so important, and the time to get in your hands on the chest is so important. And that's fine in and of itself without COVID-19. So we're well trained, well drilled, well skilled in dealing with cardiac arrest in those situations. Unfortunately, sometimes when people collapse into a cardiac arrest, a number of things can happen. So the muscle tone goes, people can regurgitate their stomach contents, people become incontinent of faeces and urine. There's lots of different things that can happen, which is incredibly distressing if anyone else is around, any family member watching that. However, CPR and intubation are two bits of a longer chain of cardiac arrest management. So you may be pushing air into someone's lungs through manual ventilation, a bag valve mask you've probably seen in any number of ambulance dramas, and that can sometimes generate particles, and sometimes, particularly if someone has been sick or has vomited into their airway, we need to suction that out so that we can maintain a proper airway. So there's lots of factors within that that make that whole process very, very difficult to isolate two specific things. And I think that plays again into my kind of comment about not reading the room and understanding how people actually have to do their work. So to isolate two of those aspects is again incongruous in terms of the whole cardiac arrest management. There may be cardiac arrests where indeed they're, very simple. The airway isn't soiled, there isn't anything in the airway, and you can do CPR, and there is nothing particularly generated. But you never know. You just never know, and each person is so very different, and you can't dynamically risk assess that when you're on the scene to do that. You should just be fully protected. So if you imagine, inherently in every healthcare professional's DNA is to preserve and save life. So when someone has collapsed, you want to just get to their side and help them where you can. And the PPE thing was difficult because the guidance was that the first person would go out in a fluid-resistant surgical mask and do basic procedures until the other attendant could don level 3 PPE and then go and do some more intricate airway management, for example. So,
if I just pause you there one moment, how long roughly would it take to don that PPE before the second person could come in and assist?
Anything realistically from 3 to 5 minutes. At the beginning of the pandemic, it was towards the end of that timescale. Certainly as the pandemic progressed, people were much quicker at being able to don their PPE and get to the side of the patient. So what everybody was keen to do is that someone was starting to compress the chest, for example, but our members said it's a frightening thing because we don't know if we're exposing ourselves to risk. So sometimes when, certainly some of our members said they went in without any PPE at all because they were so focused on supporting patient care. It's not ideal, but in reality, things happen that you can't control.
And in terms of the different approaches that we just discussed, how did the college support its members around those two different sets of statements, those two statements?
We found ourselves in a really difficult position because we knew that our evidence, that our statement was contrary to the national guidance. But we have really intelligent members who are healthcare professionals who understand that sometimes evidence will be different. We, as the professional body, have an absolute right to say we think that this is the evidence, this feels like the evidence. Other people who are eminent in this field, like the Resuscitation Council, feel the same way we do. And what we urge you is to take precautions where you can and just to think about your safety and the safety of others around you when you're doing that. Now, we know by issuing that puts a dichotomy into play of what do I do? Do I not do that? Do I not do it? Even if we hadn't said anything, the Resus Council were saying that they are the eminent people in resuscitation as far as we are all concerned in the pre-hospital field. So we knew we'd be causing additional anxiety, but sometimes you just have to tell the truth and lean in and say what you think is right.
And in terms of that evidence that you were just referring to, did you feel, or the college feel, that there was sufficient evidence and information from the national decision makers and those producing the guidance at a national level as to the reasons and the evidence base that informed their decisions and guidance?
Yeah, well, yet again, there was no pre-hospital evidence. So the paper that kept being quoted was the Tran et al. That was a hospital-based study in a closed environment with anaesthetised and paralysed patients. Well, that's not the patient that we find in the community who's collapsed in cardiac arrest. So there was no evidence, and when we were challenging that, it was like, well, that's the only evidence we have, so we're going with that. But we're saying, but common sense would tell you that the reality isn't like that. You're not in a confined room with HEPA filters where there are a number of people around. It's normally you and your crewmate in a toilet, with respect to trying to carry out a cardiac arrest in a very small space.
And were those, the issues that you've referred to around this guidance, were they pervasive across the UK?
Yes.
You said earlier on this morning in your evidence that the general view of paramedics, or certainly one of the views was that the transmission of COVID-19 was airborne. What led to paramedics forming that view?
So most of the time it was sitting in that environment with the patient. So if you speak to a number of our members, they will tell you they can probably identify which patient they caught COVID from because of the length of time they were in a confined space. And we've heard previously in the inquiry about the environment that people are in for prolonged periods. Well, 6, 10, 12 hours in the back of an ambulance is a prolonged period. And it was not when they were doing an AGP, it was because a patient was coughing or they were having a conversation with a patient if they were well enough. So it's through experience that they decided that, that it wasn't AGP related necessarily. It came from a breadth of ways. They were really conscious also that there was a lot of discussion about spreading healthcare worker to healthcare worker, but also they were worried about them passing and transmitting the virus onto patients as well who were already unwell. So there was just through their own experience, really.
Moving on to a different topic, and this is around the risk assessment tools that were available to employers and managers that were managing people that were obviously on the front line, but also in non-clinical settings, emergency operation centres as well. Were you aware of any risk assessment tool specifically for ambulance services during the pandemic?
No. Other than the Royal College of Nursing, who published one latterly, and we'd had sight of a draft copy, and that we felt that there was a lot greater experience and skill in the people doing that. So we just contributed in terms of remember those that are in the ambulance service.
And in May 2020, a letter was sent to ambulance trusts from the National Ambulance Black and Minority Ethnic Forum, referring to a national risk assessment tool. Is that right? So that wasn't specific to the ambulance sector?
Not as far as I'm aware, no.
And in your view, was that appropriate for use in the ambulance sector?
I can't recall it specifically, but there are very few things that translate well into a pre-hospital setting because it's a different environment. So, the concept of the Royal College of Nursing risk assessment was almost starting from the beginning. So make sure you're competent to undertake a risk assessment and understand what you're trying to do. Then look at the training and look at the what your mitigations can be. So that felt more appropriate. But the ambulance sector is quite often a bolt-on or an afterthought, I would have to say.
Moving now to a different topic. This one is in relation to conveyance to hospital and decision support tools available for that decision making. I'd like to put on the screen, please, the INQ 304995523. And it's page 21. This is the response received, again, from the research survey the inquiry commissioned into the escalation of care and decision-making around conveyance or non-conveyance to hospital during the pandemic. And you can see the headline at the top here, that a majority, 71% of those that responded, agreed that during the pandemic, patients they were unable to escalate were more severely ill compared to the 12 months before. There's also on this page a quote from a paramedic at the bottom, which the paramedic said, as a paramedic working for the ambulance service, I was advised to use different physiological parameters to contribute to discharging care at home. Patients were being left at home with lower oxygen levels than would be acceptable pre-pandemic. Did the college receive any feedback or comments from frontline paramedics about the absence of any kind of national tool or any support that was available to them for decision-making in the circumstances of the pandemic?
No, only through conversations with some of the medical directors who were working on some of the guidance changes. So pre-pandemic, if a patient had a parameter of a low oxygen level, that would normally indicate that they needed to go into hospital or were being supported by a community team of, a community rehab alliance, for example, where a multidisciplinary team might come in and support a patient normally, even though their oxygen levels were lower because of a condition that they had. During the pandemic, people's oxygen levels, if they were unwell or clinically vulnerable, were greatly reduced. And sometimes normally fit and well people had low oxygen saturations as well. So we knew that some of the guidance was being done by the medical directors. So we asked them to keep us in the loop in terms of understanding how they were setting the thresholds, why they were setting them, what the evidence was, etc. But it's something that the college wouldn't necessarily. We're quite often involved in the clinical guidance, but during the pandemic, these were decisions that were having to be made very quickly, and with the best intentions for the most people.
So from what you've just said, can we understand that there were different approaches taken across the ambulance trusts, across the whole of the UK, to conveyance and non-conveyancing decisions to hospital during the pandemic?
Yes, the Association of Ambulance Chief Execs doesn't cover Scotland and Northern Ireland as part of their membership, but certainly the conversations they were still included in those conversations.
Moving on to the topic of mental health support and well-being. You exhibited to your statement a study of sickness absence levels, including for mental health conditions during the pandemic, which found that 50% of ambulance staff were experiencing burnout, and 87% had moderate to high levels of depersonalisation towards their work, caused by lack of management support, involuntary overtime and poor work-life balance during the pandemic. And you also exhibited a report from Nuffield Trust suggesting that 1 in 10 paramedics had left their job in the 12 months to June 2020. Can you provide some examples of the type of mental health support that was made available during the pandemic, and any that were that you received from feedback were effective or perhaps not effective?
So we have the ambulance staff charity, which is a specific charity for anybody that works or has worked within the ambulance sector, and they provide counselling. So that's free at the point of the person accessing it, and we referred people there. NHS practitioner health also included latterly paramedics as well as doctors and nurses, which was very welcomed. We'd managed to source a grant that hopefully would send people through NHS practitioner health, and then NHS England announced that NHS practitioner health would encompass paramedics and ambulance clinicians as well. And we also linked in with some organisations like Mind Over Mountains and Black Dog Outdoors and Surfwell, because what we found throughout the pandemic is that the talking therapies were good and useful and helped a number of people, but their trauma was so great that actually it was physical therapy with trained counsellors that really seemed to resonate with our members. So, for example, we taught them hill guiding, learning to surf with trained counsellors who were also ex-police officers and could surf. So it was unlocking that kind of physical activity that really seemed to do something for our members that we hadn't seen before in the talking therapies.
And it's right, isn't it, that the college produced guidance for managers to support the mental health and well-being for ambulance personnel in a pandemic crisis in April 2020?
Yes, that's right. We recognised that this was novel for everybody, so the managers would be dealing with staff anxiety, stress and depression on a scale that they had probably never dealt with, and we felt it was incumbent upon us to support the managers in how to support their staff as well and offer a guide.
And then at paragraphs 62 to 64 of your statement, you've discussed the impact of long COVID on the ambulance workforce. Can you explain what the impact has been and whether support, if any, has been made available, has been sufficient and effective?
I wouldn't be able to comment about whether it's effective or sufficient necessarily, but what we recognised is that a number of our members and people who aren't members of the college are experiencing long COVID. They can now no longer work. The ambulance staff charity, who we link in with, also spoke about they'd spent some of their funds on fitting stair lifts for paramedics. They can't even walk up the stairs without becoming breathless, so can no longer fulfil their role and have had to leave. And what we did see is that the kind of sickness payments changed, and after a certain amount of time, people were no longer being paid sick if they were diagnosed as having long COVID. And you know, we offered some long COVID support through an e-learning package, but We're not a trade union. It's a difficult space for us to be in, but we just had listening events for our members to contact us about anything they felt we could signpost or refer them on to.
You have provided in your statement a number of recommendations, and I'd like to ask you in a moment whether there's any that you would like to draw particular attention to. But before I do, we've been asked by some of the CPs to ask about specific recommendations. And the first is to whether the college thinks that it would be beneficial to have a single source for all guidance available.
Definitely.
So are there any other recommendations that you would like to draw attention to?
I think that the sort of pragmatic, evidence-based, clearly communicated policies would just be so helpful. To change things 5 times a day in a workforce that doesn't have access to its emails, etc., is just not. It doesn't work. Compassionate leadership, I know Professor Gould spoke about this last week, about hearts and minds, and just showing some compassioning and active listening and involving some of those people in the decision making or on the periphery of the decision making would be really helpful. And more awareness and support for mental health and well-being. This has devastated our profession. And I can't speak strongly enough about that. I know it's devastated everybody, but we're seeing for the first time less people applying to become paramedics. We're seeing people leave early. This cannot happen. We need to support our people. And if I may, Miss Hans, I don't know if it would be helpful to yourself or Milady, but I have drawn a template of the back of an ambulance that you can stand on, not for now, but for later, just so you can visualise the space that people work in. So I'll give it to the witness team.
Thank you. I'm very grateful, Ms Nicholson. My lady, that's all the questions.
And I don't think there are any core participant
No, there's no further questions.
I gather you've been following our proceedings in this module, Ms Nichols.
I have, Milady.
I have to tell you, it shows. So thank you very much for your focused and very constructive answers. Did you, in following proceedings, see the impact film at the beginning?
I did with John. I did, Milady.
All the films are moving, and for those of us who have to watch them more than once, I can tell you they tug at your heartstrings. But if ever there's a moving one, I thought that his account was extremely moving. So thank you for all that obviously you and your colleagues do, and thank you for all your help in this module.
Thank you so much. Thank you for including us in the inquiry. Thank you.
My lady, may I please call Dr. Michael Mulholland?
Thank you, Mr. Mills.
He will affirm.
I do solemnly,
sincerely and truly,
declare and affirm
that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Thank you, please.
Thank you.
Your full name, please.
Michael Niall Connor Mulholland.
Dr. Mulholland, you are the Honorary Secretary of the Royal College of General Practitioners. That's the RCGP.
Yes, that's correct.
You've provided a witness statement for the transcript. That is reference INQ 000339027. Introduce us, please, Dr. Mulholland, to the work the RCGP performs for its members.
Thank you. The RCGP is a professional membership organisation, a body of about 54,000 GPs across the UK. Our charitable object is to encourage, foster and maintain the highest standards of general practice in the UK. We work to continually improve patient care, support GPs to develop their care and their skills, and promote general practice as a discipline through all stages of medical training, from medical students interested in general practice right through to senior and retired members.
And a little bit about you, please. How long have you been a GP for?
I've been a GP for 26 years.
And did you work as a GP throughout the pandemic?
Yes, I was in my practice Unity Health in Buckinghamshire, where I'm a partner.
Can I begin, Dr. Mulholland, with the condition of general practice prior to the pandemic? At paragraph 8 of your statement, you say this: it was widely accepted that there were not enough GPs to meet the level of demand prior to the pandemic. Are you able, in respect of each of the 4 nations, to set out, 1, the workforce issues that were faced, and 2, what action was being taken by the respective governments in response?
Thank you. Excuse me. As you say, general practice was already close to breaking point when the pandemic hit. It was widely accepted there weren't enough GPs to meet the level of demand prior to the pandemic. In England, the government had recognised this and in 2015 committed to expand the number of GPs by 5,000 by 2020, and in 2029 recommitted to make it 6,000 by the end of the parliamentary...
Could you go a bit slower?
Sorry.
Sorry. Yeah, it's just that we do have to make a note of what you say.
And by 2019 committed to have 6,000 by the end of the Parliament. However, despite those commitments, figures published by NHS England showed that we knew that the number of full-time equivalent GPs has been falling since 2015. In Scotland, we had a report from the college in June 2019 making it clear again that general practice faced significant workforce challenges, highlighting the 4% decline in GPs between 2013 and 2017. And we called for the establishment of new targets, encouraging the Scottish Government, who committed to 800 additional GP headcount by 27, that this was not a reliable way to do it, as headcount and full-time equivalent GPs are different, and they would not meet that target, was our opinion. In Wales, there was a similar story. Our report of 2018, again presented to the First Minister in Wales, highlighted there would be a shortfall in GPs, and that the budget invested in Wales was only 7.3% of their budget, of the healthcare budget, and this compared to a UK average of about 8%, 8 to 9%. The First Minister at the time took the report and said they would work more with us to try and improve that. Northern Ireland, again, a similar picture where the number of GPs, both in headcount and full-time equivalents, was falling, and the investment into general practice was not sufficient to meet that and improve it over the time.
That's workforce. Is it right that in 2019, the RCGP published reports demonstrating the need to invest in the digital infrastructure in general practice?
Yes. We recognised that there was a need for digital improvement. There was also a need for infrastructure improvements across the general practice estate in all 4 nations.
Can you help us have a sense of the specific issues you are highlighting with the problems within the digital infrastructure?
I think in the digital infrastructure, we're not just talking about AI or ways to improve consultation. It was simple things like the number of laptops, the number of desktops, the telephony services that were not adequate for the demand that was coming in to the practices. And often GPs were frustrated by the time it took for systems to turn on, time for systems just to get going before we could even start our day to talk to patients. It was highlighted at our national conference. Dame Helen Stokes-Lampard pointed that out about 4 years ago.
Taking all of what you have told us together, how would you characterise the resilience of general practice in early 2020 as it was on the precipice of the pandemic?
I think general practice has kept going for many years despite always being underfunded, and GP resilience does keep the service running at that stage, but general practice was in a precarious place where the extra burden of a pandemic was not something that we thought we would be able to deal with.
Next, please, I'd like to consider the fluctuations in the workload of GPs across the pandemic. Please can we have on screen INQ 000 492277. Thank you. For context, these are the results from the RCGP's survey of workload in general practice in Wales, conducted in December 2020. And I'd like us to consider the average capacity figures along the bottom row. So we have pre-COVID, 108. First peak, defined here as the first 4 to 6 weeks of the pandemic, 90. And then finally, current, i.e. in that last week within December 20, 127. Can I start with that decrease in capacity that we see in the first peak? Can you help us with what factors contributed to that decrease? And if it assists, Dr. Mulholland, I'm at your paragraph 77.
Thank you. And I think at the start of the pandemic, patients were understandably extremely scared of doing things, of coming in to see health services. We had seen on TV images from Italy and China before that of what's health services being overwhelmed. And so patients wanted to keep themselves safe. They didn't want to attend face-to-face appointments. GP surgeries were in buildings, often in an old estate, where it was very difficult to isolate and keep yourself separate. And the way of general practice working over the years had been that people sat in crowded waiting rooms waiting for a doctor to call them in for an appointment. So people did not want to be in that situation at the start of the pandemic. Government messaging at the same time had been stay at home, protect the NHS, and patients very reasonably decided to do so. They did not want to leave their houses if they did not need to. And so patients were listening to that messaging as well as having the fear as well. Together.
Do I take it that as well as the fear, there's perhaps a pervasive sense of guilt about going to overwhelm the NHS by turning up to their GP surgery?
I'm not sure if it was guilt, but patients certainly felt that they were being encouraged not to attend the NHS and the service could be overwhelmed, and they did not want to contribute to that. The disruption of services as well meant services and practices and elsewhere were not the same as normal. We had been instructed by the NHS to move to a total triage system where instead of patients coming in to book appointments, that they came in online or on a phone system, after which they got a phone call back. And that was an unusual way of consulting. Some practices had started that before the pandemic and were doing it. But for most patients, it was a new way to contact the GP. And so that new system, again, created probably some barriers when it was almost imposed overnight.
I'll ask you about those barriers in due course, okay. Dr. Mulholland. Returning to this page, of course, we have here 127 capacity in December 2020. Yeah. Can you help us, at what point during 2020 did the workload of GPs start to increase after that first peak?
I think after the first peak, we had a period, as I recall, of lockdown being lifted and patients started to try and come out of their homes and see people. We had a period in the summer that year where I think Eat Out to Help Out occurred, and patients had started to return, but also had become sicker, having not seen GPs. And so people had illness that needed to be treated that was getting worse, so they started to come back and need to be seen in practices. Getting to the end of 2020, we started to have the vaccine programme and developments were being made to try and have vaccination.
We'll come to that.
And we also had that doctors were becoming ill and practice staff were becoming ill. And so there was a reduction in the service that could be provided. So those that were working were at times working, as it says here, at 127% of capacity rather than below it.
Next, please, the move to remote care. At your paragraph 86, you describe how prior to the national lockdown in March 2020, 70% of GP appointments were face-to-face. Then, during the first lockdown, we see the inverse, 70% of GP appointments conducted by telephone or video. Yeah. Help us, what was the impact of this on GPs and their patients?
This was a complete change to the way that most of us had worked before. It was overnight we had to learn new skills, how to consult over the telephone and take most of our information from the telephone rather than seeing people face to face. For patients, they had to get used to giving information that they normally wouldn't give on a telephone to healthcare staff. They usually keep private things for face to face. They had to get used to sharing these things. Our consultations changed a bit as well, and we started to look at we had to look at remote consultation as a new way of consulting, because a lot of our assessments for GPs during their clinical examinations, the MRCGP exam, were based on face-to-face consultation. And mentioned later in our evidence that we had to stop the clinical skills assessment early in the pandemic because we could not bring trainees and GPs from around the country to a central base in London to assess them. And during the first 12 weeks, we did start to introduce a new examination, which we conducted for the first time in July, based on remote consultations. So it was a completely different way of working for the GPs and for patients to access that care.
Thinking about patient access, were some patients left behind by the move to digital consultations?
I'm sure there were. Not everybody was set up, as many GPs weren't set up to be able to do digital consultations on day one. As I said, our telephone systems weren't always adequate, our IT systems. And when people were starting to try and do what everyone else was, which was work from home, we found that GPs weren't in a position to do that because we didn't have the hardware in terms of laptops to take home and access our clinical systems from. So that was happening in the healthcare system. Our patients who had a varying level of digital literacy and access to the tools, again, had the same problems, which some really find it very hard. If you'd imagine patients, my practice has a lot of elderly patients, many with hearing problems, and they find it hard to hear someone on a telephone. And when our phone lines weren't as good as they are now with our new digital systems, they find it very hard to communicate their issues and what was needed. They've said, "I want to see you, doctor," which was what they usually said on the phone when we did it. So it was much harder for them to communicate. And as GPs, we normally take a lot of our cues from how a patient looks, what's in front of us. We were having to learn as well with these patients how they were, because it was very hard over a telephone.
You say at your paragraph 89, you've touched on it this afternoon, that the way that patients were triaged went through a dramatic transformation. Can you describe that to us?
What had been traditional in general practice was that patients either walked into a surgery or phoned up the surgery and talked to our receptionists, who then added them usually to a GP or a nurse or other healthcare provider list, and they would then be seen by that GP usually. Sometimes they had a telephone call, but it was usually allocated on that basis. And the triage or the care navigation was made by our reception and teams in general as to who was the most appropriate to see the person.
Could you slow down?
Sorry, I'm going too fast again.
It's very difficult to change your speech patterns.
And so when that was happening, when we changed to a telephone system, in some ways there was good things that a GP was the person that the patient first talked to, and that a GP made some of those decisions. But it also meant that patients weren't used to it, and they often were then told, "We need to see you again because we can't get all the information from the telephone, or you're not able to share all your information." So it required a whole different way of us thinking about contact. Some places used a digital system with what's called asynchronous consultation, where someone puts a message in and gets a reply later. And again, that was completely new to many patients.
So what kind of consultation?
Asynchronous.
Asynchronous.
So they didn't occur at the same time.
Please can we have on screen INQ 000 492268. Dr. Mulholland, these results are taken from an RCGP survey of members at the end of March 2020. I'd like to consider the response to 4E. If we add those very and quite important figures together, we get that 95% of respondents thought it was either very important or quite important to receive more guidance on how to manage appointments with a mix of remote working and triage. Was this level of concern something that the RCGP raised with either the Department of Health or NHS bodies?
I'm quite sure it was. It was something that we were all familiar with from our practices, that we needed more information to be able to change our practices overnight to a new way of working. And we didn't have national guidance on how to do this, just that we should be doing it. So the very important and quite important seems what we were experiencing at the time and reflected what we were trying to put forward in our advocacy for our members to policymakers.
Can you recall what, if anything, came of those conversations?
New guidance, further guidance did come out once further calls had been made and time had been there. We also became involved in writing guidance on remote consultation and and how to do safeguarding, which was a real concern to us remotely, that we knew that safeguarding was something that even very early in the pandemic we were clear could be at risk. So we were part of those writing teams too.
Next, can we go to INQ 00492276, please? These results come from a survey conducted in September 2020, so sometime since the March results we've just looked at. The question is this: which of the following do you need to ensure general practice can get the most out of remote consultations? I'd like us to consider the fourth row down. We have 90% saying it was important to have a method to quickly identify patients that should not be given a remote consultation. Firstly, are you able to give some examples of patients who should not be given a remote consultation?
I think some of them I've talked about already, the elderly with special sense impairment who may not hear you well on a telephone. There are other groups of vulnerable patients, those with safeguarding issues, for example, we would probably want to see face-to-face. Others in our learning disability, with learning disabilities, you'd probably want to see, because of the communication that you might lose if you were not seeing them face-to-face. There are some more physical things that we'd want to see face-to-face as well. Those people with abdominal pain, we often want to feel their abdomen in an examination. So what we were finding at that time was that we didn't know exactly who should, and often you would have a telephone call and then realise through your telephone call, which obviously occupied an appointment, that you needed another appointment. And GPs were recognising that it would be better to get those patients in straight away to a face-to-face consultation rather than telephone.
Given the issue was raised in March 20, was it concerning to you that in September 2020, general practitioners were saying a method to quickly identify these kinds of patients was still needed?
I think it was a concern, but not surprised, as GPs had changed completely the way they had been taught to consult and how to make decisions from face-to-face consultation to something completely new. And there was learning that was happening at pace as to what groups, but it wasn't defined clearly. No one had told us how to do it. It wasn't part of a training that we'd been able to do beforehand. So GPs were learning this as it went along. Guidance at the beginning maybe could have helped further, but I'm not sure that if it existed anywhere at that stage.
Moving on slightly to paragraph 97 of your statement, you say that the RCGP identified a media narrative that purported to blame GPs for the perceived lack of face-to-face appointments. First, can you help us with when this narrative developed?
I'm not sure that I can pinpoint an exact time, but probably after the first wave. During the first wave, there was times of everybody being very supportive that doctors were at work. But as people perceived that general practice was closed, although we weren't, the media narrative seemed to grow. And many of our members reported and felt unfairly blamed for what was coming out in newspapers and reports that wasn't then being countered by anybody else to say, no, GPs are at work, GP doors are open, and they're working in this new way that is different, but it is not that they're closed.
In November 2020, the RCGP launched the campaign General Practice is Open. Mm-hmm. What was the aim of this campaign?
The aim of this was primarily to build on what we've been saying since April 2020, that patients who were unwell or had symptoms that they would normally go to a doctor with should still be contacting their GP. Just because we were not seeing as many people face-to-face did not mean that they should not be turning up. It meant that we would just take their history over the telephone rather than in a consultation in our room. Those people that then needed seen, we would still see. But we were very concerned that we knew that there were people who would have, as Professor Edwards said this morning, many people who would have diseases developing who did not seem to be coming into our rooms and seeing us in the same way.
Please can we have on screen INQ 000 474 283. Thank you. This is an extract from the report produced by Professor Edwards. And I just want to read from the second sentence of paragraph 44. While general practice remained open, these changes made general practice more difficult to access at times, creating a misperception that general practice was closed to the public and that services were not operating. Now this, public messaging that general practice was open could and should have been clearer. This morning during his evidence, Professor Edwards said there could have been a stronger, more coherent campaign. What are your reflections on that?
We would agree with Professor Edwards that our members felt that there was not enough clarity saying that we were open, that we were doing what had been directed that we should do, which was go to total triage and stop our face-to-face appointments as many face-to-face appointments. And that was not backed up in statements. And right through to November 21, when it was suggested that there might be a table at GPs doing how many were doing face-to-face and how many not, which led people to feel that there would be a name and shame campaign for practices. GPs reported to us that they were feeling attacked, got at, despite working at more than 100% of capacity throughout certainly 2021. So I think we would agree entirely with Professor Edwards that a concerted campaign to say that general practice was open would have made a difference.
New topic, please. Workload prioritization guidance. Could we return to INQ 000 492268, please? This time the response to question 2A. Again, this is the end of March 2020 survey, Dr. Mulholland. We have 92% of members either very concerned or quite concerned about being able to provide a business-as-usual service to patients. Was it in response to this level of concern that the RCGP and the BMA produced guidance for GPs on workload prioritisation?
Yes, we were very concerned that we knew we did not have capacity to see everybody, but we're also very concerned that we do an enormous amount of chronic care for long-term conditions in general practice, and that was not happening in the same way as it had pre-pandemic. Our members were concerned about those patients being left without the care they normally had, but what we needed to do in the pandemic situation was actually have a prioritisation that we really would call those patients that we knew were most at risk, and that is why we tried to produce it. We tried to produce the guidance more with NHS England as well.
Well, we'll come on to that, Dr. Mulholland. Let's look at the first iteration of that guidance, if I may. That's INQ 000 280 653, published on the 10th of April 2020. If we move down to page 2, we see that services are allocated as being high, medium or low priority. I'd just like to consider together how the RCGP and the BMA approached the challenge of categorising services in this way. So help us, please. What factors brought a service into the high priority category?
I wasn't part of the group specifically writing it at the time, but it was those people that needed care as normal today, that their illness would deteriorate, their health would deteriorate as a result of not having the care, put them into that category. In the lower priorities were those things that might have been checks, things that like coil checks and non-urgent screening, we thought did not need to be part of the priority of a GP during the lockdown phases and the early waves of the pandemic, but instead we should be prioritising the urgent care, the chronic care for those that were most unwell, to make sure their health didn't deteriorate, or those that had become acutely unwell, that they got the treatment at the time.
Next, let us look at a version of the guidance published in January 2021. That's INQ 000280654. And on page 3, we have this table setting out various COVID-19 response levels. Can you help us with what these response levels were designed to achieve and how they interacted with those 3 categories of prioritisation that we've looked at in the first iteration of this guidance?
I think the COVID response levels from memory were related to the government's response levels, the levels we were at. And so the guidance was trying to make it fit with that. They're very similar in some ways, that the prevalence higher, rising rapidly side was more akin to do the green work and only prioritise the green levels. As the response went down to level 0 and pandemic over, you're back to doing everything that you were doing before. So it was trying to work with these new levels that we had of COVID response, and trying to say to GPs, we don't have exact things you should be doing. You're a patient, you can make clinical decisions yourself. But these are the sort of messages we'd like you to think about when you're making those decisions in your practice.
You alluded earlier to the RCGP approaching NHS England, seeking to co-produce updates to this guidance. Did NHS England agree to co-produce or endorse the guidance?
They didn't.
Did they give reasons why not?
We recognised there was a need for speed. Our GPs were asking us, particularly for that first piece of guidance, for the guidance very quickly and to help them make decisions on the ground in practices with patients. NHS England felt that their sign-off process for guidance going out as a joint piece of work would take some time, and as BMA and RCGP together, we felt that was too long for our members to actually wait. So we went ahead and produced it together, having discussed it with NHS England and CQC.
In your view, was there any discernible impact of NHS not endorsing the guidance?
Yes, there was, and there was concern from our members at the time that by not having the endorsement of a national body, rather than a membership body, meant that our members weren't sure who was taking responsibility for these decisions. And inevitably it fell back to the individual doctors who made the decision on the day to do it. And they sometimes didn't feel that was an appropriate level of risk that they were taking if they decided if they decided to follow guidance and not do everything they normally did. And the risk was to them then, if something happened afterwards and they were criticised, who would be there to protect or indemnify them, saying this was a national piece of work. It didn't happen. We couldn't provide that as a college, nor could the BMA as a union.
Next, please, the vaccine rollout. You alluded to this earlier this afternoon. Is it right that this was a critical work stream that impacted the ability of GPs to deliver their business as usual care during the pandemic?
Yes, the vaccines came on December 2020. The first vaccination was given, the first vaccination in general practice about 10 days after the first one in the country. And it was something GPs had been involved with from the start. The RCGP wrote guidance on mass vaccination around April 2020 when we were thinking of what would happen to our flu campaigns for the winter, and safe guidance was written that in fact became the basis for a lot of the national guidance. But what it meant was that although the initial plans had been for mass vaccination hubs to maybe take the bulk of the work, patients wanted it done and trusted GPs and places where they knew vaccination was given safely year after year to do this for them, particularly with a new novel vaccine that hadn't been used before, and when they had not many of my elderly patients, when they came to the first vaccine clinic in December 2020, it was the first time they'd left the house since the beginning of the first lockdown. So they wanted somewhere safe, somewhere they knew, but it meant that a lot of our workforce was diverted for a time into delivering vaccines.
And just to give some figures to this point, you explain at your paragraph 78 that between December 2020 and June 2022, primary care delivered over 63 million vaccinations in England.
Yep.
At paragraph 65, you say that by the end of October 2021, GP practices and community pharmacies had delivered 71% of all doses of the COVID-19 vaccine administered in England. Does that give a sense of the scale of it?
It was enormous scale that it was happening on across the whole country, where GPs, practice groups, and communities had got together as GPs and our teams to do this. And many teams and many volunteers joined in that. So it often felt a community thing as well. Our volunteers from various surgeries would man the staffing of it and the security and all those things. And people came together to deliver millions and millions of vaccines.
Can we please have on screen INQ 00492272? These are results from a survey the RCGP published at the end of January 2021, so in the early stages of that vaccine rollout. In the first row, right-hand column, we have 81% of respondents concerned about being able to deliver essential business-as-usual work on top of the vaccination programme. Mm-hmm. In your view, was this fear borne out as GPs played their part in the vaccination effort?
I think GPs are very good at turning their hand to the immediate work that needs done to help and protect our patients. And we know that the work of many of the chronic clinics that we do, many of that follow-up side, the long-term conditions, probably did take a back seat as we provided acute care for those that needed it on the day and immediate care, and for the vaccine clinics. Staff were diverted, and with time we saw that different groups of people were able to do the vaccine clinics, and it didn't require so much of a clinical GP or nurse-led programme. But very early on, it was predominantly practice staff that were doing the vaccinations.
New topic, please, the impact of the pandemic on the mental and physical health of those working in general practice. On mental health, can I approach this topic by looking at two surveys conducted by the RCGP, one in July 2020 and the second in December 2020. The first, please, INQ 00492269. Let us consider the responses to question 17. To what extent, if at all, would you say your experience of working in general practice during the COVID-19 pandemic has had an impact on your well-being? If we net those responses, we have net positive 25%, net negative 46%, neither positive nor negative 27%, don't know 1%. Now, no matter how many times I try and add those up, I make 99. But setting that aside, would it be fair to describe this as a mixed picture?
Yes.
Next, let's go to the December survey, INQ 00492277. We have the same question at 9. This time, the net negative figure is 80%. Taking these two results together, what do they tell us about the experience of working in general practice between July and December 2020, Dr. Mulholland?
I think they reflect some of what we had in that earlier slide, showing that the workload had increased between the beginning of the pandemic and the 127% the Welsh GPs reported by December 2020, that the workload was going up, the demands were higher, the stresses were higher. Many practices had seen both doctors, staff, patients get sicker during that time as well, with lots of anxiety about what the right thing was to do, both in practice and personally at home, where many of our colleagues and staff had been affected personally by COVID, impacting them with illness.
Can you help us with the attrition rate during, and please don't limit yourself to the second half of 2020, but throughout the pandemic? Did you see an increase in the numbers of people leaving general practice?
Sorry, I don't have that figure to hand.
Anecdotally, can you help us, Dr. Mulholland?
I think anecdotally we're aware that people found it very difficult. Those who had vulnerabilities did not want to work. We had great difficulty early in the pandemic with a lack of central guidance as to help stratify the risk that clinicians would face. So many organisations created their own risk stratification, and practices were often left to design or choose what to use to say whether it was safe for staff to work or not. My own practice, doctors of a minority ethnic background, we supported them to stop seeing patients face to face, which naturally created an extra stress for others, but they felt a real vulnerability during that time. And for some of those doctors, fortunately not in my practice, but others did find that they did not want to return to face that afterwards.
Just on that point, at your paragraph 106, you say this: there was a lack of guidance from the NHS on which staff should be considered as most vulnerable to COVID-19. Help us. In the absence of such guidance, what did individual practices do to assess the risk?
There was some guidance came out from different groups. One I remember from the British Association of Physicians of Indian Origin, one from the General Practice Committee, I think it was, of the BMA, that gave us some guidance based on what we thought the risks of COVID were at that time, whether it was ethnicity, age, obesity, other things were in those lists of vulnerable categories. And practices often wrote to their staff and said, where do you fit on these? And then rated them on that. And practices then had to make a decision for themselves whether they could run the service and who worked and who didn't. So it was very much an individual practice decision as to who was able to be off and who couldn't. And smaller practices really struggled because they may have only had a few members of staff there. To have someone off meant the service wasn't able to be worked.
In your view, is that a good situation for individual practices to be in?
No, it wasn't. And I think, again, part of that was, certainly in the early parts, we didn't have the access for people to work from home where they could have worked more safely remotely. They all felt, in many places, had to be in work, seeing patients face to face where their risks were much higher.
At your paragraph 52 onwards, Dr. Mulholland, you set out a number of actions that the RCGP took to support the well-being of GPs. Mm-hmm. Can you take us through some of those, please?
The RCGP pivoted all our work in March 2020 to focus entirely on, as we saw the pandemic approaching us and going to affect healthcare in England or in the UK, that we thought we needed to actually purpose all our work into helping GPs get through this. So we started to focus our advocacy, was to help advocate for policy and make sure that NHS England and the other bodies were all focusing on what GPs needed in that space. We also developed resources for our members and developed what was called the COVID Hub, where we had resources explaining initially what the virus was, what we thought the symptoms were, what their response should be, right through to ethical concerns that we may come to later. We had over the first year of the pandemic, 1 million hits from healthcare practitioners across the world, because we opened this up not just to our own members, but to all healthcare practitioners worldwide. And in that space, we had 1 million hits, people looking for the information that as RCGP, we pride ourselves on what we put out as continuing professional development resource is reliable, it's accurate, it's evidence-based, and that then became a standard that others could use wherever they were.
Can I ask you about testing? It's right, isn't it, that early on, the RCGP pressed for GPs and their families to be prioritised for testing. The phrase used was to test, quote, the right people at the right time. Why was it so important to prioritise GPs for testing, in your view?
I think we recognised that GPs are the front door of the NHS for most people. We do 1.2 million consultations a day normally. And if that clinical frontline workforce was not available, there was a huge gap for the NHS, which would then struggle to provide the care that many patients needed at that time. We extended it to families because we knew that if a family member became ill in the immediate family, that often meant that the clinician was also off work. Clinician, also our receptionists, the admin teams that back up general practice day to day, we felt it was important to keep that service functioning as key frontline NHS work.
At your paragraph 121, you tell us this. In December 2021, the chair of the RCGP was still expressing concern that GP staff were struggling to access COVID-19 tests. Is that a real concern to you that even at the end of 2021, GPs found themselves in this position?
Absolutely. It felt at times that general practice was a second thought or an afterthought in planners' minds, that hospitals were often prioritised as we saw it in the thinking that was going on, and general practice and the services and the testing and everything else came as an afterthought to that.
You're not in their minds, but help us, as someone who has been with the RCGP in an active role for some time, why do you think it is that general practice becomes, in your words, an afterthought?
I think general practice has often felt that there's a lack of what we call parity of esteem between primary care and our secondary care colleagues, and that has been something that has gone on for many years. In the context of the pandemic, the primary care sees patients one at a time, usually fairly quietly. People don't come into our rooms to see it. We have someone with a bad infection, we refer to a hospital. We don't have the same services and excitement, if it were, of an A&E department where things are happening very rapidly and quickly and ambulances go to them. We have usually quite quiet conversations. Our consultations are very different. So general practice is a different environment, and the funding of the NHS is over 90% to secondary care services. So that's where many perceive the NHS works. The 10% or the less than 10% in general practice can't be perceived as less important potentially to some if they're thinking in big picture terms.
Finally, my lady, before perhaps we take an afternoon break, can we return, Dr. Mulholland, to my favourite survey, INQ 00492268. This is the end of March 2020. Question 4B, please. On PPE, 94% of respondents thought it was very important or quite important to have more guidance on how to use PPE. Can you help us? In which particular areas were GPs most searching for further guidance? Are we thinking about fitting, when to wear it, what to wear in certain situations?
All of those. And what to use, what we had, what we should be doing with them. Excuse me, there was a concern that rose as we saw PPE being used in other countries, on television and the news, that what we were being told about in the NHS was different, what was being supplied to us was different. We had reports from GPs of out-of-date PPE arriving at their practices to be used that had gone past their best before dates. We had concerns that the WHO had issued guidance that was different to the UK guidance, which naturally made GPs anxious that we wouldn't be seeing patients in well air-conditioned, ventilated places. We would be seeing them in a consultation room, potentially in a building that wasn't entirely fit for seeing patients, an old converted house or whatever. And so we were very concerned.
Dan, please, I'm not
Sorry.
surprised. Stronfa's doing a brilliant job, but
I'm
it's
racing
really
ahead.
difficult.
Apologies, my lady. We were concerned at the amount or the adequacy of the PPE that people were receiving, and if it was adequate, that we didn't have sufficient information to reassure our members that it was adequate and the appropriate thing for us to be using.
Did the RCGP take action to try and resolve the issues its members were raising about PPE?
Yes, we publicly expressed concern on 26th of March 2020 about the availability and guidance for PPE and wrote to the Secretary of State for Health and Social Care, asking for clarity as to what was happening and asking about whether GPs should begin wearing PPE for all face-to-face consultations, because even at that stage, after the national lockdown or around the time of the national lockdown, we still did not know whether there was a national recommendation for us to use face-to-face or use masks in face-to-face consultations. We continued to advocate as we went along. We recognised there was an improvement in PPE a week or so later when some guidance came out, but there was still concerns amongst members whether we had the right face masks, whether the guidance we were being given was correct, and whether the eye protection was needed, things like that weren't entirely clear.
My lady, I'm about to move on. Would that be a convenient moment?
Certainly. I hope you're warned that we take breaks, Dr. Mulholland.
Thank you.
I shall return at past.
All rise.
Mr. Mills.
My lady. Dr. Mulholland, shielding. At your paragraph 155, you say the decision to designate some of those at high risk to be part of a shielding group caused an immense amount of work in general practice. What steps did someone working in general practice have to take in order to first identify and then second communicate a person's shielding status?
The shielding policy came in at the end of March 2020 when GPs were informed and asked to identify the most clinically vulnerable, which meant us, A, knowing a list of those people thought to be most clinically vulnerable, then doing searches on our practice computer systems to try and identify those people, following which they needed to be contacted by the practice teams in some way to inform them of this, and then put in the steps and inform them of what else needed done after that.
Were there issues caused by the function of data, for example, issues with how illnesses or medications were coded, or examples of prescriptions not making it into a person's medical records?
Indeed, yeah. The patients that were clinically vulnerable with the disease that we had coded in general practice were relatively straightforward to search for. But there were medications that sometimes were prescribed by hospital specialists that identified someone as being clinically vulnerable, and they were then needed to be searched for in hospital systems that don't connect with our own general practice ones, and somehow that information shared between us. There was then other challenges that required the secondary care and primary care systems be connected by NHS Digital to make sure that we could really identify those. Patients were also asked to self-identify at one stage during the early stage of shielding, and those records all needed checked back to make sure they were the people that had been prioritised and set out as being clinically vulnerable. Sorry, my lady.
In your view, had there been conflicting communications about who needed to shield?
Some of the variation was based on our understanding of COVID-19 at the time, that initially we thought that people with diabetes should be shielded and then shouldn't be shielded, and at a later stage went back onto the shielding list. The groups that needed to do the searches hadn't been set up before the announcement was made, and so the data was not flowing between our organisations to patients. It seemed to be going backwards, that patients were aware that there was going to be shielding, after which we were doing the searches, after which our secondary care colleagues were trying to connect with us to make sure the searches were correct, leaving the patients vulnerable and confused at the end of it all.
Were there instances of patients calling their GP practice to say, I think I ought to be shielding, I haven't received a letter, can you help me?
Absolutely, yes. We made many, many calls from patients asking just those questions, because they had understood from what they had read or seen on the news that they were in the shielding groups, although sometimes the detail of what the shielding group was hadn't been communicated in those reports. So they weren't actually in the right groups, but required our teams to spend time going through that data very carefully to work out, often leading to some difficult conversations by admin staff or the doctors, clinicians themselves, trying to explain why someone who felt vulnerable wasn't on one of these extremely vulnerable lists.
Was there flexibility within the system for a GP who had a patient not on the shielding list to advise them to shield nonetheless?
We could advise any patient to shield if we thought they were vulnerable, but it didn't always connect then with the national picture of who should be. And at the start of the pandemic, there were some things that happened if you were on the extremely vulnerable list, like there were food delivery prioritization, because people were staying at home and not going out. And that didn't happen for those patients that we identified necessarily.
Moving on, please, Dr. Mulholland, to DNA CPR. At paragraph 208, you say this: there was a lack of central guidance for GPs on DNA CPR and how best to implement the policy. Help us, what was the basis for your view there?
The RCGP doesn't and still doesn't have a role in formulating policies. And we recommend that for clinicians and GPs on the ground, that every DNA CPR decision or advanced care planning decision is one taken by the clinician and the patient in a shared decision-making process where they decide what the best options are for our patients, and they decide the best option for themselves. And we come to an agreement about that, about how they want to proceed with their care and future wishes should they die.
At 211, you say you heard nationally that GPs were pressured to make these decisions, DNA CPR decisions, at speed and without time for adequate discussion with patients and families. What were the causes of that pressure?
We'd heard of reports where GPs being asked to do frailty scores, and at the time, NICE, the National Institute of Clinical Excellence, had set out some guidance for those working in the intensive care setting or the hospital setting as to who maybe should be, how you would prioritise using a frailty score for those going forward for intensive care treatment. And it seemed that, although we don't have exact information where this happened, that some GPs were being asked to do frailty scores on either patients in care homes or their elderly or more ill patients, and complete escalation plans and document DNA CPR decisions or CPR decisions.
Please can we have on screen INQ 000 400 508. We will come to the substance of this in a moment, but we can see here, can't we, that on the 1st of April 2020, a joint statement on advanced care planning was published, which the RCGP co-authored with the BMA, the Care Provider Alliance and the Care Quality Commission. Can I start with this? What prompted the development of this joint statement so early in the pandemic?
I think it's what I just referred to, that we were hearing reports of information being completed by GPs, either being encouraged to by systems or because they felt that was the guidance they were getting. And some of them were feeling pressured, they were feeling uncomfortable, they didn't feel it was the right thing to do, and were informing the college that this was happening. And we felt it was very important for our patients and our members that we set out as clear guidance as we could, that we still believed everything that we normally did, that a shared decision-making process was the way to make these decisions, not blanket decisions for populations.
How is a statement like this shared with those working on the ground in general practice? Do they receive an email?
I can't remember the detail of how we did it, but from the RCGP, we would have put it in our weekly blogs, we would have put it in email correspondence that we have with members, and I suspect the other organisations were doing similar, so we hoped that we would convey the information out as fast as we could to as many doctors as possible.
Can you take us through, Dr. Mulholland, the instructions contained in this statement and help us with what it was designed to achieve?
The statement talks initially about the importance of having personalised care plans, which we believe is what every patient should have as their care is becoming more complex. We discuss what we prioritise, what we don't. Specifically, older patients, those are frail, serious conditions. And during the pandemic, these conditions were worsening, and COVID was making some of these patients very ill. It moves on to talk about capacity, and what we believe is that every patient that has capacity has the right to make their own decision, and it should be discussed with them. An advanced care plan is what you put together with the patient, not something that you provide for them. And if someone doesn't have capacity, we work with family carers, those responsible with them, to make what's called a best interest decision for the patient, involving as many people as we can who know the patient well. Sometimes an advanced care plan in some of my palliative care patients includes a statement where they've decided that should they die, they do not want cardiopulmonary resuscitation attempted. And we would put that into a care plan for some of those patients that are often on a palliative care journey because of a cancer or some other illness. But these are individual decisions. They were individual before the pandemic. We recommended and said they should be individual decisions during it, and we continue to work on that basis. And then the last statement was because of the thoughts that the things that we'd been hearing, it is unacceptable for advanced care plans with or without a DNR form to be applied to groups of people of any description, because that immediately removes the individual choice. And that was just something we thought was such a clear line. We needed to reiterate it to all practitioners as fast as we could.
Thank you. Can I return momentarily to the concerns that were being raised? You've said GPs were being asked to make these decisions. Can you help us? Who was asking GPs to make these decisions?
We understood that some of these were coming from the healthcare system, so CCGs or otherwise, and whether it was formally or an informal feeling that GPs had to protect the NHS, they should be limiting the number of referrals into hospital, or setting out advanced care plans that would say, I do or don't go in for further care, or I do or do not receive resuscitation. So it was informal feedback that was coming into us, but we understood it to be from clinical commissioning groups who were the system providers commissioners at that time.
After the publication of the joint statement, those concerns continue to be raised with the RCGP, or was a real change perceived?
We heard from GPs who felt pleased that we had made such a clear statement and so quickly in the early pandemic. We also went on to produce very clear guidance. We involved the Royal College of GPs Ethics Committee, who spent time working with the teams to produce, on our COVID hub, an ethical resource hub, which included how GPs could approach end-of-life decision, advanced care planning decisions, working through it with scenarios that they could learn from. So it was a learning place as well as a reference point that GPs who were dealing with difficult ethical issues at the time, we'd be able to work through and see what best practice should look like.
Can I move to our penultimate topic, Dr. Mulholland, long COVID? Please can we have on screen INQ 00492271. These are the results of an RCGP survey conducted between August and September 2020 about long COVID. Let's consider the answer to the second question. Do you have a long COVID clinic you can refer to? 23% yes. What did the 77% of GPs who did not have access to a long COVID clinic in practice do with patients who presented to them with long COVID symptoms?
In practice, they would have had to manage them themselves as best they could with the information available. The RCGP had started to hear concerns about patients having prolonged symptoms following an infection with COVID quite early on during the pandemic, and we started to talk with our research colleagues around the country to look at it. We monitored feedback and talked to members, and RCGP then joined for the first time with NICE, the National Institute of Clinical Excellence, and signed the Scottish Guidelines Network to write the first definition of long COVID or post-COVID syndrome, as it was known then, as joint stakeholders or joint writers with the two guideline organisations. In that, we started to set out what was known about long COVID or post-COVID syndrome, set out symptoms that GPs could start to look for and recognise, and the best practice that we knew of at the time in terms of management of long COVID symptoms.
Finally, this, lessons and recommendations. We began your evidence this afternoon, Dr. Mulholland, by exploring the resilience of general practice at the start of 2020. Can I ask you this? If another pandemic was to strike next year, in your view, is general practice in a better or worse condition to cope now than it was in March 2020?
I think general practice is probably in a worse condition than it was at the start of March 2020. Demand and responding to patients' needs and access and the requirements has risen. Our waiting lists across the country in all hospital specialties have risen dramatically, and that workload, while patients wait for care in a hospital, ends up coming back to GPs and our practices and our practice teams. We feel that to be able to meet current demand, let alone a pandemic or a stress on the system from another illness that came through the country, we need to be significantly better resourced, significantly better both in terms of finance coming in, but workload and workload reduced and workforce increased to make it possible to be able to treat the number of patients and provide the care for them that is needed. So that we could both continue to treat the new illness as well as manage all the illness that's in the community already and our patients and our populations need looked after.
Dr. Mulholland, thank you, my lady. That's all I ask.
Thank you, Mr. Mills. Ms. Lengar. Although it's natural to look at the questioner, Dr. Mulholland, it's really important we get your evidence transcribed. So keep speaking to the microphone, please.
Dr. Mulholland, I appear on behalf of the long COVID groups. I have a number of questions in a very short period of time. My first question is from the perspective of the physical impact of long COVID on your members. You've said in your witness statement, it's paragraph 110 for your reference, that many GPs have been impacted by long COVID and that several of them are no longer able to work because of ongoing symptoms. Are you aware of any support that is specifically available for GPs with long COVID who are no longer able to work?
I'm not aware of any particular support for GPs with long COVID beyond what is available on the NHS for everybody. There are various services from practitioner health, the NHS and the NHS GP service, but not specifically for long COVID. But we're aware of that group of GPs that have had COVID during the pandemic and since, that now have symptoms that are stopping them working. And as mentioned in our evidence, there isn't a GP occupational health service. It doesn't exist, and that is something that would be a development that would allow us to be able to get proper help for those GPs that become ill.
So that would be a development that you say is necessary?
Absolutely.
Thank you. And then my next questions look from the other side of the coin, the impact of long COVID on your members as clinicians caring for patients with long COVID. You said this afternoon that quite early in the pandemic, GPs started observing and reporting to your college that a significant number of patients were presenting with what we now know as long COVID. Are you able to assist us with a timestamp of what is early in the pandemic, roughly what month the college was receiving these reports?
One moment while I tried.
You refer to quite early in the pandemic. It's 195
95.
of your witness statement. There isn't a timestamp in the statement itself.
I think at that stage it was anecdotal. We report that in July 2020 we were talking to our clinical advisor group, seeking their opinions on. Our clinical advisors are a group of GPs who work for the clinical policy team and provide advice and support when we deal with consultations, when we have clinical questions. And it was from that group that we understood that this was becoming an increasing phenomenon throughout the country, that patients were having these prolonged symptoms.
So those conversations began in July 2020. So is that when those reports would have been received by the
reports would have been received before July.
Before July.
And then put to our advisors for confirmation in July 2020.
Thank you. And you've explained that the college engaged directly with decision makers and politicians, and you've named the Secretary of State for Health, the 4 CMOs, Sir Simon Stevens of NHS England, Public Health England, and the DHSC, who you say you lobbied to commission the NICE guidelines on long COVID. Would those reports of the significant numbers of patients with long COVID have been shared with any of those stakeholders that you were in conversation with?
I'm sure that the information would have been shared with them at the time if they were being lobbied. I wasn't in the meetings, so I'm afraid I don't know that detail.
So you can't tell us which of those bodies the college might have shared the early reports of long COVID with, but you assume that they were shared?
They would have been shared. I'm just checking my notes, but we were talking to NICE and SIGN from around July, August 2020. At that stage, I'm sure we would have shared it in other meetings that we were at, as the evidence, or as my report said, that we were having consultations weekly with NHS England, Sir Stephen Powis and Sir Chris Whitty during that time, and we would have been bringing it up in discussion in those meetings, but I don't have documentation for those.
So the CMOs would have known by then, by July 2020. Thank you. And surveys carried out by the long COVID groups in September 2020 and then again in April 2021 record that many patients reported not being believed by their GPs for the symptoms they were suffering from, and GPs not knowing how to help them. And that's something that's mirrored by your college's own surveys. You were taken to the survey of September 2020, where GPs say they were not very confident in treating patients with long COVID symptoms. Dr. Mulholland, do you believe that the NHS and Public Health England could have done more to support primary care clinicians in anticipating and responding to long COVID?
I think as it was the second new disease our members were facing that year, they were learning how to understand it. It was unexpected that came out on top of the pandemic and the COVID infection itself. The support from around the healthcare system would have been appropriate and good if we had all had more of it. It was the RCGP that we wrote a top tips document for GPs. We approached NICE and SIGN and got this done because we felt that was the fastest and most appropriate way we could get that information out to our GP colleagues.
And my final set of questions, Dr. Mulholland, is on data collection and coding of long COVID by GPs. Firstly, and very quickly, Professor Hopkins of UXA said in oral evidence last week that there isn't standardised coding of long COVID, which is not correct, is it? Because you say at paragraph 201 of your witness statement that RCGP created new codes for long COVID as soon as the NICE definition of long COVID was published in 2020. So codes were in place for long COVID by December 2020. That's right, isn't it?
That's correct. I think it was called post-COVID syndrome, was what it was classified by NICE, and that's what we worked with the PRSB, the Public Records Standard Body, and NHS Digital to have put in place.
And in relation to that coding, both NHS England and your own college have noted that coding on long COVID is essential for public health planning. So we need to know how many people are suffering from long-term symptoms in order to model demand and plan for service delivery. And the college, your college, in June 2021 reported to the Long COVID Ministerial Roundtable that one of the key areas it was working on was improving coding on long COVID, because there was a disparity between coded figures and ONS figures on the prevalence of long COVID. My question, Dr. Mulholland, is: has the use of coding for long COVID in 2024, so now, has it improved so that it's an accurate data source for prevalence of long COVID?
I'm afraid I don't have that information.
And finally, Dr. Mulholland, my question involves looking forward and your opinion whether you can assist the inquiry with any observations on how improvements could be made to ensure that accurate and consistent use of coding systems for long-term sequelae of novel viruses by primary care practitioners are correct from the outset.
I think the model that we had where NICE and SIGN and the RCGP worked together to define the condition, and then our work to get coding systems in place was the start of it. The next step would have been to potentially spread this wider and make sure that it was in everybody's consciousness, I guess, that we use it the same way as we use other codes. People probably were still learning about the disease in 2021 or the end of 2020, and time would be to develop that, but it could still be developed that people should be able to use the code more as it becomes more familiar. There was the challenge as well within this one that some people called it long COVID and other post-COVID syndrome, and I'm not sure whether that made a difference in the number of coding episodes we have on the computers.
So, Dr. Mulholland, just following on from that, when you say that it's in everyone's consciousness, can I glean from that that you mean that there's more training and more education on the coding of long COVID to ensure that primary care practitioners are consistently applying it and understand that post-COVID and long COVID denote the same illness?
Yes.
Thank you. Thank you, Dr. Holland.
Thank you, Ms Langer. Mr Thomas, I think you've moved over there. Yep. That way, Dr Mulholland.
I'm representing FEMHO, the Federation of Ethnic Minority Healthcare Organisations, which advocates for the health and well-being of Black, Asian and minority ethnic healthcare workers and patients who were disproportionately affected by the pandemic. FEMHO is particularly concerned about how the pandemic impacted patient contact and access to care for ethnic minority patients. In your witness statement, you mentioned various factors that contributed to the fall in patient contacts during the pandemic. Question: were there, in your understanding, reduced contacts from Black, Asian, minority ethnic patients during this time?
Yes, I believe there was a reduction in all groups of patients, but possibly particularly.
Building on that then, you discussed the shift to remote care during the pandemic in your statement. FEMHO's concerned about how this move might have impacted Black, Asian and minority ethnic patients, especially in terms of their access to primary care. Question: so how did the move to remote care impact the ability of Black, Asian and minority ethnic patients to access primary care during the pandemic?
I think in the evidence we described that there is a risk of a digital inverse shared care law, as Professor Edwards described the shared care law earlier, about some populations not getting the care despite the need. We recognise that some populations didn't have the same digital access, as others. And I think some of our work in the Health Inequalities group has shown that some of the Black Asian minority ethnic groups fall into some of those places where digital access was less available, and so that would have impacted them adversely.
Well, just a follow-up, what was done to address that?
By ourselves, our Health Inequalities group worked very hard to try and help members recognise groups that could be adversely affected. On our COVID hub that I described earlier, we did have a particular section written by our Health Inequalities group at the college, outlining ways that groups might be contacted, might be noted, might be supported in different ways. And that included not only Black ethnic, minority ethnic community, but also those with learning disability and others that may not be accessing the service in the same way.
Lastly, FEMHO's keen to understand the issue of racial bias in medical devices, particularly the pulse oximeter, which you refer to in your statement. You see, this is of particular concern given that Black, Asian and minority ethnic patients were disproportionately impacted by COVID. So question, what, if anything, was done by the Royal College of General Practitioners once it became known that there was racial bias in the pulse oximeter?
We became aware of that when it was published in December 21, I believe, 2020, 21, I can't remember which one offhand, and would have informed our members. I looked earlier and don't have a record of the communication. It may have been through our chair's blog, which went out weekly, but we wanted to inform members in subsequent webinars or resources that were published. It would have been highlighted in that as well, so that GPs became aware that there was a bias in the way that pulse oximeters picked up readings.
Would you agree that more could and should have been done? Would you agree with that?
Not being able to exactly recall what was done, I'm not sure. I think once we found out about it, there was a need that we did inform people and that people were aware very quickly with that pre-Christmas period that pulse oximeters were not providing accurate readings.
Thank you, Dr. Mulholland. Thank you,
Mr. Thomas's question. Pulse oximeters weren't new for the pandemic, were they?
No.
So, I suppose, why was it took so long for anyone to recognise this potential for racial bias, as Mr. Thomas has called it? I appreciate, Mr. Thomas, you may have felt you were excluded from asking that question, so...
Thank you, milady.
That part I'm not aware of. The first research we heard of was New England Journal of Medicine, and very quickly after that, people were made aware that this existed, but why nobody had thought of it and explored it before, I don't know.
So roughly how long had we had these devices in common practice?
They'd become cheaper in common practice and general practice in the past decade, but they've been around in hospital medicine for many years before that.
Millie, can I just one small? I mean, see, we're talking years, aren't we? That these devices have been around.
Yes.
Thank you, Mr. Thomas. Mr. Wagner, where have you gone? Oh, there you are.
Thank you. Good afternoon. I ask questions on behalf of the clinically vulnerable families. I have two areas to ask you about. The first is infection prevention and control in GP surgeries. At paragraph 77 of your statement, you say that one of the factors which, in your view, led to a fall in patient contacts was, and I quote, patients being understandably scared of attending face-to-face appointments. GP surgeries are often in buildings where it's not possible to have comprehensive infection controls, and there is a large overlap between the groups who attend general practice most frequently and those who are most at risk from COVID-19. Do you agree that further improvements to infection prevention and control, particularly to building design and ventilation, remain necessary in GP practices?
Absolutely. I think we're very aware that GP practices have often been set up in buildings that aren't suitable for modern healthcare and have been adapted and improved to make them fit for purpose, but could have significant changes in the way they are designed from the original. My own practice, which was was a 5-site practice across a rural community, a very small, 5 small practices. We actually had to close one of our practices to patient contact during the pandemic because it was an old converted chapel that did not have sufficient ventilation, did not have sufficient space for patients to move around it, nor for our staff to feel safe within it if consulting with patients who were infected. So I think, yes, there's a real need for many of these older buildings that we have in the general practice estate across all 4 nations needs to improve to be adequate for some of the modern infection prevention and control.
Thank you. And would you agree that if that was done, it would be helpful in addressing the ongoing problem that some vulnerable patients feel it's not safe for them to access those GP surgeries in those older buildings?
I would hope it would, yes, that some of the patients who are aware they're vulnerable because of drugs they're taking or illnesses they have may not want to sit in a waiting room with other people who are coughing, sneezing, whatever else in it. And so if we had better spaces and bigger spaces, they may feel safer in that.
And better ventilated spaces.
Better ventilated, yes.
Is that fair? And would you also agree that that would help GP practices better prepare for a future pandemic?
Yes, a lot of time went into GPs trying to work out how to separate hot and cold or red and green parts of their building at the start of the pandemic, with many practices really struggling because they had one way into the building and one way out. Some were lucky to have a way in and an exit that others could leave through, but it became very difficult for many practices in buildings that weren't ever designed as purpose-built health centres to find their way through that.
Yeah. So you referred to hot and cold. Can you just explain what you mean by that?
We often referred to the places where you would have COVID or acute infections as the hot area, and patients that were coming for follow-up of long-term conditions without an infection as the cold area, or the red area and the green area. It was just ways of describing different places where you needed different areas of prevention and control in them.
Thank you. And the second and final area I want to ask you about is shielding. You said in your oral evidence, you said there were some difficult conversations by admin staff, all the doctors and clinicians themselves, trying to explain why someone who felt vulnerable wasn't in the extremely vulnerable list. Can you expand on why those conversations were difficult? And was that confusion, in your experience, causing some distress amongst the patients?
Yes, it was causing distress. It's hard to remember back to the beginning of the pandemic, looking from where we are now, all in a room together, but patients felt so anxious that they could be the person that got COVID at that stage and could become really ill because we saw it happening around us, that the greater protection you could provide for yourself and others could offer you seemed to be, for many, the best way forward. So for someone to feel that they were vulnerable enough that they were prepared to isolate for 12 weeks and not talk to someone else or be in their space, my parents had to do it, and they reluctantly said goodbye to the grandchildren and all that sort of thing. For them to feel that concerned, if someone had turned to them and said, actually, you're not that vulnerable after all, you're not as sick as you think you are, was very difficult. And it wasn't saying it that you're not as sick as you think you are, because we often knew that these people were very ill. They just did not hit the list of criteria that we'd been given. And so for elderly people, some of my patients are very elderly but have very few illnesses, and sometimes they didn't actually hit the criteria that got them into the clinically extremely vulnerable group. And it was a very difficult conversation to say to someone, well, I'm sorry, I know you're at risk, but on this list I have, you don't fit that criteria.
Thank you.
Thank you, Mr. Wagner. Ms. Munro, I think it's you.
Good afternoon, Dr. Mulholland.
Good afternoon.
My name is Alison Munro, and I ask questions on behalf of COVID Bereaved Families for Justice UK. My lady, in fact, most of my questions have been addressed either by Counsel Mr Mills or indeed answers that Dr Mulholland has given to other CPs this afternoon. So just a few matters, please. In relation to shielding, you've just been asked about shielding, but just after our afternoon break, and in answer to some questions from Council Mr Mills, re-shielding, you told us what GPs could advise compared to what support patients had access to, etc. Now, my first question was on flexibility of GPs. That's been covered, but sort of bringing together your written and oral evidence, it seems that what you've described is a lack of clarity and changes within the groupings for those who were defined as clinically extremely vulnerable. So bringing that all together, Dr Mulholland, in your opinion, was it clear to GPs who should or shouldn't be included within the formal shielding categories and what discretion they had over this?
I don't think it was entirely clear, because some of what we were working from was what we thought should be in the shielding category, like people with respiratory illness initially were thought to be at risk and later less so. So much of what our experience had been as GPs was based around the flu pandemics and the swine flu and things in the past. This was an entirely new disease that we were dealing with, and nobody was quite sure what made someone extremely vulnerable, but we're seeing very quickly, and from other countries, that some people were more vulnerable than others very clearly, but we didn't quite know who they were. We had to go on the guidance that was given to us on the basis that it was given by experts, and we had to trust that. But we didn't have enormous flexibility to change it. We could agree with someone if they wanted to stay at home and self-isolate, as some of my patients did. We could support them in that way and deal with them from telephone calls and home visits if needed, but we couldn't actually add them to this clinically extremely vulnerable list.
And just following on from that, Dr Mulholland, do you feel that that lack of discretion for the GPs was a hindrance and potentially a great difficulty for patients?
I think I can see it from both sides, that there were times when you thought your patient was vulnerable, but the evidence we were being told was, no, that group wasn't. The risk would have been that if GPs had a lot of flexibility, many more people could have been put into the group to shield and isolate unnecessarily. I can see for other patients that we knew very closely, because there are patients who we know their illnesses and what's going on, that maybe they did have other risks that weren't part of that, and the lack of flexibility putting them into the groups might have hindered the individual. So as a population level, we might have increased the groups massively if we'd gone for what we thought was right rather than the evidence we had. But on an individual level, some flexibility would have been useful.
Thank you. Next question, my last question, in fact. Different topic. In relation to reports that GPs are asked to do frailty scores, and you touched upon frailty scores this afternoon, Dr Mulholland, can you comment on whether this practice disproportionately affected older people and those with disabilities?
I think all frailty scores are higher, or you have a higher index of frailty depending on the other illnesses you have, disability, age. So yes, it would have had more impact on that group because they would have had higher scores, or depending on the scale, this would have been higher up the frailty index.
Thank you. My lady, the other questions were on PPE, but those have been sufficiently covered this afternoon, so thank you.
Thank you for your help, Ms Monroe. Dr Mulholland, thank you very much for your help. I'm very grateful to you. I hope we haven't kept you too long today. But what you have to say is obviously extremely important with relation to primary care. Thank you.
Thank you.
Very well. 10 o'clock tomorrow, please.
All right.